going to talk. You have got a PowerPoint in your pack, which you can go away and peruse at your leisure, which gives you the detail of what I'm going to say. For me, what we're about in sunny Wigan, which is the second biggest borough in Greater Manchester, population of 350,000 people, only the city of Manchester itself is actually bigger than us, is an interesting challenge because we're part of a bigger conurbation. So, key message to start off with is, what's your geography? If you're going to be making a decision, is it just going to affect a small community, your organisation, a group of organisations, a borough, or a big conurbation? And one of the things we've done in terms of the moving the transition forward is to think about how we actually do things once across the 10 boroughs of Greater Manchester. We're very fortunate we've got an existing infrastructure, the Association of Greater Manchester Authorities, chaired by my own council leader, Lord Smith of Lee. And we have a history of collaborative working between health and local government. The 10 DPHs across Greater Manchester work as a team. We are embedded within the commissions led by AGMA, including the Health Commission. And one of the things we decided very early on in terms of strategic decision making was that decisions around whole systems, health and social care, should be done at a Greater Manchester level. Because if you looked at our view from the moon, which I've got in your slides, it's a very complex, integrated system. And making decisions in Wigan impact on Bolton, Salford, even Trafford to the south of us. So, message number one about that, get your decision making right. My second message is, and this will sort of sing to Mike's heart, is what are you trying to achieve in terms of your health and wellbeing board at a local level? And like Coventry, we have taken Marmot to be the heart of our joint health and wellbeing strategy. My JSNA isn't done as a one-off document, and it's certainly not 500 pages, and it's certainly not just done on deficits. We're doing a quarterly electronic version which integrates intelligence across all parts of the system. Because I think one of the lessons for us is we all have intelligence, every discipline, every tribe, I'll call them tribes because it is tribalism, isn't it, folks? And we all think our knowledge is better than everybody else's. And my vignette from the current quarterly part of the JSNA, which we're looking at health protection in the round. And having a conversation with my colleagues in trading standards, we found they have a wealth of data, huge amount of data, but because they haven't put it together with health and other data, we haven't got the full benefits of all the data they collect. So another key message is identify all your sources of data and look at how it's put together to create intelligent reports. Because I've set the challenge to our analysts. So if I'm sitting on the Health and Wellbeing Board, and by the way, my attention span is also short, folks, as a Director of Public Health, I want 2 sides of A4 max from intelligence. I don't want a huge document. Director of Public Health saying they don't want a huge document. Heresy. But it's true, because I want to be able to make decisions. My time is short, and I need to be able to make decisions fast. So, for me, it's about timely, robust, and very comprehensive intelligence synthesised. Are we making best use of that? So, have we identified our sources? And for me, the asset model is absolutely key. So when you see my next Director of Public Health Annual Report, which is out in 2 weeks' time, folks, and it will be webbed, so you can see all the videos. I'm one take Ardern now. That was a challenge to my Chief Exec to be one take Redfern. You will see from the annual report, we've based that on the new economic foundation, 5 Ways to Wellbeing. And what we have done within the annual report to complement the quantitative intelligence in JSNA is qualitative vignettes gathered through our 900 plus community health advocates across the borough, my team of 5 neighbourhood health improvement workers, or my beat cops, as my Chief of Police likes to call them, for health improvement, who work across a multi-agency operational partnership. So we're getting operational level intelligence around health improvement and well-being. And what we've done is to draw that intelligence into an asset profile for the borough. So we're actually celebrating local people's work, but also creating an asset map, so that when we are trying to use our if you like, our investments and our commissioning tools, we are able to commission according to the assets as opposed to the deficits. And that's linking into primary care at a very local level, so into CCG boards, but also into the, if you like, the assets that other organisations across the borough use. And I'm going to give you 2 vignettes to finish off, to illustrate that kind of whole borough endeavour towards health and wellbeing, and how I in public health influence other organisations. And my 2 assets, my 2 key assets and leaders, are Steve Sheridan, my Chief Fire Officer, and Sean Donnellan, who's our Chief of Police. And what we've done with Steve, and we're about to do with Sean, is to train every single member of the fire brigade in Wigan in Make Every Contact Count. So our rollout frontline staffing programme in health improvement, using the Royal Society of Public Health qualification, has been rolled out and is mandatory training. Steve has actually taken it himself. That's leadership by example, folks. He's almost as good a DPH as I am, in effect. And what we've done with that is what we're doing with that is to monitor referrals into preventative services and into how that helps Steve achieve his outcomes. Key message: common language, common purpose, common set of objectives and outcomes. I'm helping him achieve his fire outcomes, he's helping me achieve my health outcomes. What we've seen is a massive increase of people being referred into drugs, alcohol, smoking cessation services, but also, very importantly, over the last 2 months, 14 women, previously not known to services, referred into MARIC, because domestic abuse is one of our key health priorities. And as then Sean said to me only last week, Kate, if you hadn't done that, and if Steve's team hadn't referred those women, I would be seeing those 14 women on a slab. In other words, our crime stats would have gone up too. We're about to do this now with the police, because again, Sean articulates it almost better than I do. I'm helping him achieve his crime stats. And the vignette I'll give you, where we share intelligence across the police, health and trading standards, is that when I went to the guys looking at Wigan South, where we had 2 years ago 50% of the population in one super output area who smoked, the local police inspector looked at it and said, "You've got a tobacco den in there, an illicit one." The local people said, "Yeah, and we can give you the address." 48 hours later, Trading Standards, HMRC and the police raided that address, closed down the illicit tobacco den. Hey, guess what? The smoking rates in that super output area have dropped. That's how you use combined intelligence at an operational level to achieve outcomes for police, trading standards and public health. If I could give you no better illustration of how to use intelligence intelligently, that's one that really does achieve an outcome and builds a sense of common purpose and builds confidence in using public health intelligence to actually support a whole borough endeavour on health and wellbeing. Thank you very much.
Thank you, Kate. Nick, are you okay just to give us a little bit on